What are these cells that I have labeled over here?
Chief cells, sir.
These are the chief cells. Very, very good. As I told you, these are polygonal cells. See the nucleus, they're uniform and round, and look at the cytoplasm. At some places they are clear, but at some places also they are light pinkish in color. If you can appreciate, they are light pinkish also somewhere, and they are completely clear also somewhere. So it's somewhat, it lies between clear cytoplasm to light pink cytoplasm. Is this very clear? These are your chief cells. These are your chief cells, which are the predominant cells of the parathyroid. Okay. And the second, and this is the basic cell. It is the chief cell, which is basically responsible for secretion of the hormone. Okay. Parathormone secretion. Parathormone secretion is from the chief cells only. Now, the other kind of cells that we saw, if you look at the left-hand side, their cytoplasm is more intense pink, and they are a little bit larger as compared to the chief cells. So can you see this mass of cells over here? So these are basically the oxophil cells. These are the oxyphil cells. Okay, they are tightly packed with mitochondria, and the cytoplasm is deep eosinophilic, or as they call acidophilic. Is this very clear, the two kinds of cells, and which are the most predominant cell having what function? Now, this is the normal parathyroid only. Now, actually, what is happening that the parathyroid is lying very close to the thyroid. So if you look over here, this is your basically thyroid. This is your thyroid. And very close to the thyroid, the parathyroid is present. So this is your parathyroid. Now, why have I shown you this particular diagram? Just to make you understand what is this tissue? This white color tissue, what is this? Yes, can anyone tell me? Yes, so this is the normal adipose tissue that we see. This is the adipose tissue. So the normal parathyroid gland contains adipose tissue on an average 17%. Okay, this can be a little bit more or less. It is more in case of females. Okay, what is the importance of this? We will understand when we read about parathyroid carcinoma. Let us begin today's topic of discussion. Today, we are going to understand the basics of the parathyroid, and we are going to read in details about hyperparathyroidism. Okay, so let us begin today's topic of discussion. So basically, the very important thing over here is that most people are having two pairs of parathyroid. That means we are having 4 parathyroid in total. And what is the most common location of the parathyroid? So it is most commonly located in very close proximity to the upper and lower poles of each thyroid lobe. Average weight of each parathyroid, if you see, is approximately 30 milligrams, and it is slightly heavier in case of females. Okay. Now, average amount of fat is around 17% in parathyroid. So if we see the histological section of a parathyroid, you will see that the parathyroid is also having some amount of fat. Okay. And that on an average, it has a range, but if you take the average, it's around 17%. And the amount of fat is again more in women. But the maximum amount of fat that a parathyroid has develops at around 25 years of age. Now, the parathyroid, in addition to its usual location close to the thyroid gland, in addition to that, the parathyroid can also be located at other ectopic locations like the carotid sheath or the anterior mediastinum or even in the thymus. Okay. Now, we have to understand very important MCQ that is asked, that what is the normal line of development of the parathyroid. So the parathyroids can be divided into superior and inferior parathyroid. So the superior parathyroid is developing from the 4th pharyngeal arch. It is the 4th pharyngeal arch, whereas the inferior parathyroid is developing from the 3rd pharyngeal pouch. Okay, and the 3rd pharyngeal pouch is also the one which is giving rise to the thymus. Okay, now very importantly, the basic thing, if you are going through my YouTube community post, if you have gone through the basics of the parathyroid, I have also mentioned that normally the parathyroid are having 2 basic type of cells. What are the 2 basic types of cell? One is you are having the chief cells. One is your chief cells. Another one is your oxyphil cell. I will show you with the help of diagram how they look. So normally the chief cells, they are the predominant cells of the thyroid, of the parathyroid. So they are the predominant cell of the parathyroid. They are polygonal cells around 12 to 20 micrometer in diameter with a central round and uniform nucleus with very clear to light pink cytoplasm. It is not like the cytoplasm is completely clear, but it is, lightly pink, but it is not diffusely pink. Okay, diffusely pink, it is not diffusely, it is little bit light pink. And the chief cells are the one which contains the secretory granules containing parathormone. So parathormone is classically secreted from the chief cells of the parathyroid. Secondly, we are having the oxophil cells, which are slightly larger and they have acidophil cytoplasm, that is completely eosinophilic and pinkish cytoplasm. Okay, and that occurs because they are tightly packed with mitochondria. Excuse me. So which type of granules they contain? The oxophil cells are containing glycogen granules. Okay, glycogen granules. So two types of cells, the predominant chief cells, and we are having oxophil cell. The function of the chief cell is basically it is secreting parathormone, whereas the oxophil is containing, it is packed with mitochondria and contains secretory granules containing glycogen. Okay. Now, what is the basic physiology of the parathyroid? The parathyroid is associated with maintenance of normal calcium homeostasis. So what does that mean? That whenever in our body, the free calcium level or the ionized calcium level falls, that is going to stimulate the parathyroid to release a hormone. What is this hormone? Yes, can anyone tell me? It is called as the parathormone. It is called as parathormone. And this parathormone acts in several ways to increase the serum calcium level. So understand, whenever the serum calcium level will fall, it is going to stimulate the parathyroid gland to secrete a hormone called as the parathormone. And this parathormone is acting in several ways to increase the serum calcium level. So normally, how does the parathyroid gland helps in increasing the serum calcium level? First of all, it is going to increase the renal tubular reabsorption of calcium. It is going to cause increased calcium absorption from the kidneys. Secondly, it is also going to increase the conversion of inactive form of vitamin D to its active form. And this active form of vitamin D, if you remember your physiology, it increases the intestinal absorption of calcium. So this is also increasing the serum calcium level. Thirdly, there will be increased excretion of urinary phosphate. Okay, remember, normally the phosphate, what does the phosphate do? Normally the phosphate in our serum, it is binding with the calcium, leading to decreased serum calcium level. So if you excrete excess amount of phosphate, that means less amount of phosphate is available to bind the calcium. That means more amount of this calcium is present free, okay, in the unbound form. And third and fourthly, very important, there is an enhanced osteoclastic activity. So basically, the parathormone, it enhances the osteoclastic activity, which increases more bone resorption and it increases more calcium mobilization from the bone. Now here, very important, a basic concept over here is that what basically happens that the parathormone, it goes and basically it stimulates the rank ligand present on the osteoblast. Okay, and these rank ligand which are present on the osteoblast, they go and combine with the rank receptor present on the osteoclast precursors, causing the differentiation. The end result is there is excessive activity of the osteoclast. And osteoclast, if you remember, their main function is to eat the bone. So they eat the bone and they release the calcium from the bones. So by all these four processes, the normal parathyroid is going to act to increase the free calcium. Now, whenever the amount of calcium in the body will come back to the normal level, then they are going to inhibit the release of parathormone from the parathyroid. So there will be a feedback inhibition of the release of parathormone from the parathyroid gland. Is the normal physiology very clear to everyone? Yes, is it very clear? Okay. Now, if you look at this particular diagram, if everyone look at this diagram, you all tell me, what are these cells? Yes, tell me. What are these cells that I have labeled over here?
Chief cells, sir.
These are the chief cells. Very, very good. As I told you, these are polygonal cells. See the nucleus, they're uniform and round, and look at the cytoplasm. At some places they are clear, but at some places also they are light pinkish in color. If you can appreciate, they are light pinkish also somewhere, and they are completely clear also somewhere. So it's somewhat, it lies between clear cytoplasm to light pink cytoplasm. Is this very clear? These are your chief cells. These are your chief cells, which are the predominant cells of the parathyroid. Okay, and the second, and this is the basic cell. It is the chief cell which is basically responsible for secretion of the hormone. Okay, parathormone secretion. Parathormone secretion is from the chief cells only. Now, the other kind of cells that we saw, if you look at the left-hand side, their cytoplasm is more intense pink, and they are a little bit larger as compared to the chief cells. So can you see this mass of cells over here? So these are basically the oxophil cells. These are the oxyphil cells. Okay, they are tightly packed with mitochondria, and the cytoplasm is deep eosinophilic, or as they call acidophilic. Is this very clear, the two kinds of cells, and which are the most predominant cell having what function? Now, this is the normal parathyroid only. Now, actually, what is happening, that the parathyroid is lying very close to the thyroid. So if you look over here, this is your basically thyroid. This is your thyroid. And very close to the thyroid, the parathyroid is present. So this is your parathyroid. Now, why have I shown you this particular diagram? Just to make you understand, what is this tissue? This white color tissue, what is this? Yes, can anyone tell me? Yes, so this is the normal adipose tissue that we see. This is the adipose tissue. So the normal parathyroid gland contains adipose tissue on an average 17%. Okay, this can be a little bit more or less. It is more in case of females. Okay, what is the importance of this? We will understand when we read about parathyroid carcinoma. So till here, my basic point was to make you understand about the basics of the parathyroid, because if you don't understand the basics, it will be little bit difficult to understand the pathogenesis for the same. So hyperparathyroidism, that is basically the topic of today's topic of discussion. So it will be hyperparathyroidism. So hyperparathyroidism can be of three main types. So what are the three types? It can be primary hyperparathyroidism, it can be secondary hyperparathyroidism, or it can be tertiary hyperparathyroidism. So try to understand this point of difference very clearly, because multiple MCQs, approximately 3 to 4 MCQs will be asked to you from this particular diagram. So parathyroids are very, very important from MCQ point of view. Okay. So if you look over here, there is primary hyperparathyroidism, secondary hyperparathyroidism, and there is a tertiary hyperparathyroidism. So what is the meaning of primary hyperthyroidism? So primary hyperthyroidism means there is an autonomous overproduction of parathormone, but this autonomous overproduction, why is it occurring? It is occurring because of the presence of either a parathyroid adenoma. This is a neoplastic, benign neoplastic lesion of the parathyroid, or it occurs because of hyperplasia of the parathyroid tissue. So either there is adenoma or there is a hyperplasia, or sometimes in some cases it might be a parathyroid carcinoma as well, but in very few cases. But mainly majority cases is because of an adenoma or a hyperplasia. So what is the difference between an adenoma and a hyperplasia? Can anyone tell me? Remember, adenoma is basically a neoplastic process, whereas hyperplasia is not necessarily neoplastic. Is this point clear?
Adaptation.
Yes, is this clear to everyone?
Okay. Yes, sir.
Now, secondary hyperparathyroidism. What is the meaning of secondary hyperparathyroidism? Now, over here, there is a compensatory hypersecretion of the parathormone. So, the parathormone is not being produced autonomously. Over here, it is compensatory released in response to prolonged hypocalcemia. So, there is some reason or there is some cause of prolonged hypocalcemia in the body. And in response to this hypocalcemia, the parathyroid gland is releasing the parathormone so as to increase the serum calcium level. It most commonly occurs in the setting of chronic renal failure. It occurs most commonly in the setting of chronic renal failure. Okay. Is this point clear to everyone? Okay. Sir? Now there is also, yes, tell me. Just let me complete tertiary, then you may ask your question. tertiary type of hyperparathyroidism, if you see, also over here, there is also a persistent hypersecretion of parathormone. Okay, now over here also, it was because of prolonged hypocalcemia. Okay, now secondary hyperparathyroidism was also because of prolonged hypocalcemia. But the difference between this is that in case of tertiary hyperparathyroidism, after prolonged hypocalcemia is corrected, even after the hypocalcemia is corrected, okay, the parathormone level doesn't come down. Okay, so even after the cause of prolonged hypocalcemia is corrected, for example, if the defective kidney is replaced by a normal kidney, even after that, if you see, the parathormone levels doesn't come down. Just see the point of difference, try to understand. Over here, there was prolonged decreased amount of calcium in secondary hyperparathyroidism. This caused an increase in the PTH levels, and this led to normal amount of calcium. And after that, the PTH level fell down. That was controlled. But over here, something like this did not happen. For example, decreased calcium was there. There was increased parathormone that led to normal calcium levels. But even after calcium levels became normal, the parathormone levels did not go back to normal. This is the only point of difference between secondary and tertiary hyperparathyroidism. Is this point crystal clear to everyone? The basic, what is primary hyperthyroidism, what is secondary, and what is tertiary? Yes, can we move ahead now? Yes, someone was asking me some doubt. Yes, you may ask your doubt now. Yes, tell me.
सर ये जो आपने बताया कंपनसेटरी, ये कैसे रिलीज होगा? मतलब अगर कैल्शियम कम हुआ तो उसकी वजह से
what is the meaning of compensatory? That for example, if tomorrow you are playing cricket and if you break someone's car, then you have to compensate by paying the money of that. Yes or no?
Yes, sir. First aid.
Yes. So over here also, the body has some requirement of calcium. Normally, what is happening? Normally, with the amount of parathormone that is released, that is able to maintain normal calcium homeostasis. But for example, if the kidney is failing, okay, the kidney cannot produce vitamin D, the kidney cannot reabsorb calcium, the kidney is not being able to perform its function. So the body calcium level is going down. So who should compensate? Kidney is not doing its work. So the parathyroid is supposed to compensate. How it will compensate? By secreting more amount of parathormone. Is this point clear? What is compensatory hypersecretion of parathormone? Yes?
Yes, sir.
Okay.
सर एक और है.
Yes, tell me.
सर अगर पैराथॉर्मोन ज्यादा रिलीज होगा तो उसके केस में थायरोकैल्सिटोनिन से वो करेगा?
Pardon, say again.
सर अगर पैराथॉर्मोन ज्यादा रिलीज हो रहा है तो मतलब उसकी कैल्शियम मतलब ज्यादा रिलीज कर रहा है, तो उसकी वजह से क्या उसको थायरोकैल्सिटोनिन उसको एंटागोनाइज करेगा?
नहीं, वो आपका जो है वो आपका वो कंडीशन में नहीं आएगा, मतलब वो एंटागोनाइज नहीं करेगा कोई. बट व्हाट आई एम सेइंग, बिकॉज द सीरम कैल्शियम लेवल इज लेस, द बॉडी हैज टू मेंटेन नॉर्मल लेवल. सो दैट के लिए उसके लिए क्या होता है कि हाइपर सिक्रेशन होता है. कैल्सिटोनिन मतलब इज नॉट कमिंग इनटू द प्ले, इट इज द फीडबैक इनहिबिशन दैट इज कमिंग इनटू द प्ले. ओके
सर.
Shubhansh, are you there? Can you hear me?
Yes, sir, I can hear. Sir, I have a doubt. In
Yes,
the second case of secondary subtype, sir, you told that the normal level of the PTH would come down. Sir, if there is a chronic
I didn't say the normal level of PTH will come down. I said this raised amount of PTH after the calcium level becomes normal is going to come down. So PTH is going to be, there will be a feedback inhibition. Normally PTH is not always present. It will come, do its work. When the work is done, the level will go down. That is a normal feedback inhibition.
Okay, sir. Sir, and what would be the status of the serum calcium level in all the subtypes? Sir, I mean,
I will tell you in detail individually when I am going to discuss. Then I will tell you in detail the lab diagnosis of each. Then you will be able to understand properly. Okay. Okay. So first we are going to start with the primary hyperparathyroidism. So when we are looking at the primary hyperparathyroidism, what are the basic causes of primary hyperparathyroidism? Causes. Very important MCQ that is asked. The first most important cause of primary hyperparathyroidism, and in which is the basic cause of primary hyperthyroidism, the most common cause if you see is an adenoma. in 85 to 95% of the cases. So most common cause of primary hyperparathyroidism is a parathyroid adenoma in 85 to 95% of the cases. Okay, and mind it, this is a neoplastic process. Matlab, this is a clonal process. The second very important cause of primary hyperparathyroidism is primary hyperplasia, which might be diffuse. That means it can involve the entire gland. If this is a parathyroid, diffuse means the entire gland is involved. Or it might be nodular. That means some portion of the gland will be involved in the form of nodule. So these are the portions which are showing hyperplasia. Is this clear? And lastly, in 1% of the cases, as I told you, parathyroid carcinoma might be the underlying cause. Okay. So very importantly, primary hyperthyroidism, it is a disease affecting adults, and it affects more commonly the women as compared to men, the ratio being, or the incidence being approximately 4:1. Very importantly, nowadays, this primary hyperthyroidism is diagnosed incidentally. Why incidentally? Can anyone tell me why primary hyperthyroidism is diagnosed incidentally? Yes.
Due to raised calcium level.
Very good. Very good. Nowadays, in today's world, if you are going to appreciate, okay, in today's world, if you can go, if you are going to appreciate in today's world, just wait 1 second. Okay. In today's world, if you will appreciate in today's world, what you are going to see, that serum calcium levels, if you see, it is a normal, what should I say? It is a regular part of your, biochemistry panel that they are doing. So very commonly as a routine test, they are giving serum calcium. So because of the serum calcium level diagnosis, because of this, as a part of the entity of this entire spectrum of the test that we are giving, so you can easily catch primary hyperthyroidism. Is this point very clear to everyone? Any doubt? Yes, everyone. Any doubt? Okay, so let us move ahead now. Very importantly over here, if you see, the first important and the very important topic that we will discuss is the solitary sporadic parathyroid adenoma. As I've already said, it is the most common cause of primary hyperparathyroidism. Now, most of them, as I told you, this is an adenoma. Adenoma means what? It will be a clonal process. So it is a neoplastic process that we have to understand over here. Okay. So there are two very important molecular alteration that is associated with adenoma. I said two. Okay, remember there is two. Which are the two? Number one is overexpression of cyclin D1, which is present in 40% of the cases. Okay, and basically this overexpression of cyclin D1, it occurs by a basic mechanism. There is an inversion which is involving the cyclin D1 or the CCD1 gene, CCDN1 gene. So normally the cyclin D1 gene is present in chromosome 11q, and the normal parathormone gene is present in chromosome 11p. Now you have to understand over here that there is an inversion which is bringing this particular cyclin D1. So there's an inversion which brings this particular cyclin D1. It is brought very close to the 5' region of the parathormone gene. And as a result, this 5' region is driving the overexpression of cyclin D1. And if you remember, cyclin D1 is the one group of enzyme that is going to facilitate the cell cycle and ultimately leading to the proliferation of the cell. So because of this inversion, there is a direct overexpression of cyclin D1 or CCDN1 gene that will lead to cell proliferation. Okay, very clear. So overexpression of cyclin D1 is seen in 40% cases of adenoma. But remember one very important thing. This inversion that we have seen, okay, this inversion that we have seen, it is responsible for only 10 to 20% cases of sporadic adenoma. Thus, we have to understand that this inversion is not the only cause of overexpression of cyclin D1. There are other mechanisms which are not yet developed, which are responsible for overexpression of cyclin D1. Clear to everyone? Now there is a MEN1 gene mutation. Now, if you look at the MEN1 gene mutation, it is responsible for approximately 30 to 35% of sporadic adenomas. MEN1 gene mutation. I am talking about sporadic, and not only sporadic. So see, MEN1 gene mutation is present in both sporadic and familial case. In around 30-35% of sporadic adenomas, MEN1 gene mutation is responsible, which is present in chromosome 11. Whereas if you see germline mutation in the MEN1 gene is present in patients with familial parathyroid adenoma, as in conditions of MEN syndrome. Yes, do you remember MEN1 syndrome? Yes, do you remember MEN1 syndrome? It is seen there. Okay. Now, last very important molecular alteration, if you see, this CDC73 gene mutation. Normally, this CDC73 gene is encoding what is called as a parafibromin, and it is mutated in 70% cases of sporadic parathyroid carcinoma, not adenoma. Remember, this is the catch question for the exam. Okay, so the alterations, overexpression of cyclin D1 and MEN1 gene mutation, it is limited to adenomas. Okay, you will remember this point. Whereas the CDC73 gene mutation, if you see, okay, this is basically seen in 70% of parathyroid sporadic carcinomas, not in adenomas. Very rarely they will be in adenomas, and this is the MCQ which is asked. Okay, now very importantly, germline mutation or inheritable mutation involving the CDC73 gene can lead to a very, very rare syndrome, which is called as hyperthyroidism jaw tumor syndrome. Now, it is a syndrome characterized by parathyroid carcinoma. Along with that, you are having ossifying jaw tumors along with it. Okay, so is the molecular clear to everyone? What are the molecular alterations present in an adenoma and what are the alterations present in the parathyroid carcinoma? We are basically reading about parathyroid adenoma only. Now, before we start with the morphology, just what are the familial syndromes which are associated with primary hyperparathyroidism? So when a patient is coming with primary hyperparathyroidism, you also have to rule out certain familial syndromes. So if the patient, when will you suspect that the patient is having MEN1 syndrome? Yes, tell me. What are the conditions of MEN1 syndrome? Yes, have you heard about triple P? 3 Ps? Yes, very important MCQs I have given in YouTube also. Yes, do you remember? Parathyroid, pancreas, pituitary. If all the three are involved, then you can say there's a MEN1 syndrome. In MEN2, what is the characteristic feature of MEN2 syndrome? Yes, in the previous lecture only. Yes, what is it? MEN2 syndrome is associated with medullary carcinoma. Yes or no? And MEN4 syndrome, very much similar like the MEN1 syndrome, also has parathyroid hyperplasia. So these are the 4 important 1, 2, and 3. These are very important familial syndromes associated with primary hyperparathyroidism. And not only that, a very important entity that has been added and a very hot favorite question of examiner: familial hypocalciuric hypercalcemia. So first of all, it is an autosomal dominant disorder, and it is characterized by loss of function mutation in Cas-R gene. What is the Cas-R gene? The full form is, it is a calcium sensing receptor gene. Okay, so when there is a loss of function, normally they are sensing the calcium levels. Okay, so loss of function of this Cas-R gene is going to lead to decreased sensitivity to the extracellular calcium. That means higher than normal calcium levels are required to suppress the parathormone levels. Okay, so there's an increased calcium reuptake in the kidneys, and there's a decreased calcium excretion by the kidneys, leading to mild hypercalcemia and normal to increased parathormone. Abhi, if I want to just tell you in a very simple way, I will just tell you one very basic way. Have you seen means don't take it otherwise. If you see your mother or your sister before they go to the wedding, you will see that they are standing in front of the mirror from morning till evening. How many of you have noticed this? Yes?
Yes, sir.
This is the same thing over here. That means the body is not satisfied with the adequate level of calcium. Similar to the ladies and the beautiful girl, they are not satisfied with their makeup. They will keep on. So you have to have a lot of motivation. You have to tell them that, okay, you're looking very fine, you're looking very nice. Then after that, you can, then after that, they will agree, and then they will come with you to the wedding, else they will not. Okay, similarly over here, the body has to, persuade the serum calcium level. Okay, the body has to persuade with excessive amount of parathormone. Understand? So higher than normal calcium level is required to suppress the parathormone levels. Is this point very clear? Familial hypocalciuric hypercalcemia. Okay. Now we go to the morphology. Now to the morphology, if you see, we have parathyroid adenoma, we have parathyroid hyperplasia, and then we are having parathyroid carcinoma. So we are going to individually see each one of them. So parathyroid adenoma, if you see, they are solitary in nature. Means, for example, if this is your thyroid gland, okay, if this is your thyroid gland, and for example, this is one parathyroid, another parathyroid, and fourth. So when there is a parathyroid adenoma, so for example, one of them will be involved and enlarged like this. So it is always solitary. It is not that all of them are involved together. And the weight of this parathyroid adenoma is in the range of 0.5 to 5 gram. Now, these are very well circumscribed nodule. On cut section, they are reddish brown in color, and a capsule is always present. Now, glands outside the adenoma is usually normal in size or shrunken because of feedback inhibition. What does it mean? That, for example, this is the parathyroid gland, and the adenoma is developed in this particular part. So if you see this remaining part, this remaining part is containing normal glands, or these glands will be shrunken in nature. Why? Because this part is hyper functioning. So this part becomes reduced in size. I'm going to show you. Microscopically, when you examine this adenoma, you will see uniform polygonal chief cells with small centrally placed nucleus, just like the original cells. Okay. Now, you can also find very few nest of oxyphil cells also over here. But sometimes in case of parathyroid adenoma, the oxyphil cells become predominant, and in that condition, we call it as oxyphil adenoma. Is this very clear? Now, very important point with regards to adenoma is that in case of an adenoma, a rim of compressed non-neoplastic normal parathyroid tissue, generally separated by a fibril capsule, will be seen at the edge of the adenoma. This is how you will differentiate the adenoma with a hyperplasia. In case of parathyroid adenoma, you will see that a small amount of shrunken small normal parathyroid gland will be seen lying outside the adenoma, because the adenoma, see, if this is the normal parathyroid gland, and for example, this was the adenoma. So the adenoma slowly it has increased in size, and it has compressed the normally growing parathyroid gland. So you will see the compressed tissue at this particular end, and this is the adenoma that you see. So this is very important point of difference between adenoma and hyperplasia. Again, this is how we differentiate the adenoma from hyperplasia. Now remember, mitotic figure is very rare in case of adenoma, and this is how we differentiate it from parathyroid carcinoma. And as I told you, normally 17 to 20% fat is there. In any neoplastic process, if you see, whether it be adenoma or it be carcinoma, the amount of fat tissue is decreased in case of the parathyroid. Is this point very clear to everyone? Now, with the help of this diagram, I will show you. This is the entire proliferating adenoma. This is the adenoma part that has been growing. And can you see, this is this very small compressed tissue. What is this small compressed tissue? Yes, this is the normal parathyroid. It has been pushed by this growing tumor, by this growing adenoma has pushed it to the, has pushed the normal parathyroid glands. Okay. Is this point very clear to everyone? Also very important, you will see there is a fibrous capsule over here which is surrounding the adenoma. Very, very important point. Okay. Clear? Now, very important, as I told you, if the person is having adenoma, then out of the 4 parathyroid, if you see, only one of them will show the growth. So if you see one of the glands showing the growth, it is a solitary lesion. The chance of that becoming an adenoma is very high. So this is classically a technetium 99M sestamibine radionuclide scan. Over here we can see there's an increased uptake that is seen in the left inferior parathyroid gland. And this is basically containing the adenoma. And therefore, this type of scan is very important to differentiate from parathyroid hyperplasia. Because in case of parathyroid hyperplasia, what you will see, in case of hyperplasia, you will see all the 4 glands are equally enlarged. But in case of adenoma, only 1 gland is enlarged. This is how we differentiate the adenoma from hyperplasia. Is this point very clear to everyone? Let us look at this. Let us now begin with parathyroid hyperplasia. It will become more clear. Over here, if you see, classically over here, instead of a single gland, over here, all the 4 glands are involved equally. And the size is also very high, but it is often less than 1 gram. Okay, microscopically, you will see that there is hyperplasia of the chief cell. So over here, instead of one portion, if this is the entire gland, you will see the entire gland is showing hyperplasia. If this was the normal size, the entire gland has enlarged and the whole gland equally is showing. So there is no compressing of the normal tissue. That normal tissue will not be seen because all of them are basically hyperplastic. And this hyperplasia can either occur diffusely, that means how I have shown you over here, that throughout there might be a diffuse hyperplasia, or it might be in the form of nodules, as I have already shown you. Okay. Now, sometimes these cells, sometimes these chief cells can contain abundant amount of glycogen, because of which the cytoplasm can become completely clear. In that case, we call it as water clear cell hyperplasia of the parathyroid. And again, over here, the stromal fat becomes less. The stromal fat becomes less. Okay. So this is about your hyperplasia and this is about your adenoma. Do you have any doubts? Now you will be able to differentiate between adenoma and hyperplasia, everyone. Okay, is it very simple now? Okay. Now we come to parathyroid carcinoma. Now again, what is very difficult about the parathyroid carcinoma is that there is no clear-cut features like other malignant tumors. Like for example, in other malignant tumors, usually they are not very well circumscribed. But parathyroid carcinoma, it can either be very well circumscribed or it might be frankly invasive in nature. Understand what I'm trying to say? So they might occur in both fashion. They can have both fashion. Is this point very clear to everyone? Okay. One other thing over here is that usually, okay, they show enlargement of one, just like the adenoma. Malignancy is also a neoplastic process, so there will be enlargement of a single parathyroid gland. But over here, the weight increases a lot. It becomes more than 10 grams. And the cells, if you see, very funny thing is that the cells are very uniform. They resemble the normal parathyroid cells. Okay, so these can be present in either a nodular or a trabecular pattern. And the mass, just like the adenoma, it is having a very dense fibrous capsule also. Okay, so remember one very important thing. Sometimes in case of an adenoma, if the cells, if you see, in case of adenoma, sometimes in case of parathyroid adenoma, you might see certain bizarre cells. But remember, in case of parathyroid adenoma, remember, bizarre cells in other kind of tumors, we will say is a malignancy. But over here, the cellular characteristic or the cytological features, they are not helping us for the diagnosis. So bizarre cells in case of parathyroid is not a feature of malignancy. Then what is the set of criteria which has been given by the WHO for diagnosis of parathyroid carcinoma? So very important, there should be invasion of nearby local tissue or nearby organ. For example, the thyroid has been involved, or the soft tissues of the neck muscles have been involved, or the thymus gland has been involved. There should be clear-cut features of vascular invasion and perineural invasion. There should be clear-cut established signs of distant metastasis. This is metastasis seen in 1/3 of the patients. Now remember, as I told you, bizarre and pleomorphic cells, usually they are criteria of malignancy in all the tumors, but it is not a criteria for malignancy in case of parathyroid carcinoma. Very, very important MCQ. And local recurrence, that means after surgical removal of the parathyroid, local recurrence can occur in approximately 1/3 of the cases. Is this point very crystal clear to everyone about parathyroid carcinoma? Now, very importantly, whether it be a parathyroid adenoma or whether it be a parathyroid carcinoma, if I want to know what is the nature of a particular tumor, then we have to go for parathormone and GATA3. So both this parathormone and GATA3, they will confirm the parathyroid nature of the tumor. Very, very important. Okay. Whereas if you see, there are other very important markers which are very much specific for parathyroid carcinoma. So what are these? This is PGP 9.5 galactin 3, loss of expression of parafibromin, and a very high Ki67 index. All these features will differentiate the parathyroid carcinoma from parathyroid adenoma. Is this very clear? This feature, parathyroid nature, will be seen in adenoma plus carcinoma, whereas these three features will be present only in case of carcinoma. Is this point very clear to everyone? If we look at this diagram over here, you can see that these are areas of invasion. So these are the soft tissues of the neck. This parathyroid has invaded the soft tissues of the neck. If you look at this diagram, what are these? These are the muscles of the neck. And this parathyroid has already entered the soft tissues and infiltrated. So this is a clear-cut sign of invasion, which is required for diagnosis of parathyroid carcinoma. Now, if you look at the individual cells over here, they are very much looking like the normal parathyroid. So what is the difference from adenoma? If you see, in adenoma, mitotic figures were very rare, but over here you can see a lot of mitotic figures, which goes in favor of parathyroid carcinoma. Okay, is this very clear to everyone? Okay, is this very clear? Okay, the morphology when a parathyroid adenoma is present, when a parathyroid carcinoma is there, when a parathyroid hyperplasia is there. So you should be able to understand these basic points very clearly. Okay, now we are coming to the skeletal abnormalities that happens. Now, why the skeletal abnormality will be there? Because we are reading about primary hyperparathyroidism, and over here, because of an excessive amount of parathormone release, there's an excessive osteoclastic activity, and ultimately there's an excessive amount of serum calcium levels. So because of this excessive amount of osteoclastic activity, what is happening? All the calcium from the bone is coming into the blood. So what will happen? The bone will become weak or no? The bone is going to become weak. So the first important skeletal lesion over here that we see, the patient is going to develop osteoporosis. Now, what is osteoporosis? There's a decreased bone mass. Why the bone mass is decreasing? Because all the calcium is being taken away. Because the osteoclast, these are nothing but the modified macrophages present in the bone that is eating away the bone. So there's a decreased bone mass, especially very much seen in the phalanges, vertebra, proximal femur. Second very important thing, the cortical bone. Okay, the cortical bone, if you see, they are affected more than the medullary bone. And remember, in the medullary bone, if you see, the osteoclast in the medullary bone, they tunnel centrally along the trabeculae. So it gives an appearance of a railroad track appearance, also known as dissecting osteitis. It's a characteristic feature, histological feature of primary hyperthyroidism. Okay, so look at this particular diagram, you are going to understand. First of all, try to understand what is this pink color thing that you are watching. This is called as the bony trabeculae. This is the bony trabeculae. Normally, this entire thing is pink in color. But in between, what has happened? What is this? This is a mass of tissue. What are these cells? What are these cells? These multinucleated cells. These are the osteoclast. So these osteoclasts, they have somewhat eaten across the bony trabeculae, and they have made an appearance as if this is like a railroad. This is like a train, railroad appearance. And these are the tracks. These are the tracks. Can you appreciate? That is why the term has been kept as the railroad appearance, called as a dissecting osteitis. Why dissecting? Because the osteoclasts are dissecting their way through the bony trabeculae. Is this point crystal clear to everyone? Yes. Okay. The second important thing, now as the bone is becoming more and more thin, so what is going to happen? They are going to form the next kind of tumor that is called as brown tumor. Why we call it as brown tumor? Excessive amount of bone loss, they are going to cause microfractures. Now, when there will be a fracture, there will be healing. And once the healing will be there, that means what? The granulation tissue will come. So there will be a lot of fibrous tissue over there. And there will be a lot of hemorrhage over there. Because the granulation tissue is containing what? Newly formed blood vessel. Yes, there will be stromal edema. Along with that, there will be a lot of fibroblastic proliferation, which is going to lay down the collagen. Yes or no? That is going to form a mass of reactive fibrous tissue. And this mass of reactive granule, actually it is nothing but a granulation tissue. This is called as a brown tumor. Why it is actually, see, if you see, the basic concept is that of granulation tissue. Now someone has given it a special name. This is called as brown tumor. That is, this reactive reparative granulation tissue is called as brown tumor because of increased vascularity. There is increased hemorrhage. Now what happens, the new blood vessels in the granuloma, in the granulation tissue, they are very leaky in nature, so they are going to cause hemorrhage, and excessive hemorrhages will be what, will be broken down, and they will release iron that will be stored in the form of hemosiderin, and ultimately they can also undergo what is called as a cystic degeneration. And ultimately, when this cystic degeneration occurs, it leads us to the third important skeletal lesion that I'm going to discuss. So is this concept of brown tumors very clear to everyone? How the brown tumors are? These are nothing but these are organized granulation tissue only. In the end, they might develop a cystic degeneration. There will be cystic formation. And that condition is called as the osteitis fibrosa cystica, also called as von Recklinghausen disease of the bone. Okay, now von Recklinghausen systemic disease is something else. And this von Recklinghausen disease of the bone is something else. Now over here, what has happened, because of an increased osteoclastic activity that was seen over here, because of increased granulation tissue with reparative fibrosis that was seen over here, and because of the formation of the cystic brown tumors. So this cystitis, osteitis fibrosa cystica, it is nothing but a combination of increased osteoclastic activity, increased peritrabecular fibrosis, along with cystic brown tumors. Now, the most common site of this osteitis cystica is your jaws. Very important MCQs. And very important, this third important lesion, it is mainly seen in case of primary hyperparathyroidism, but it might also be seen in secondary hyperparathyroidism, but it is quite less severe. It is very much less severe as compared to the other. So is this point very much clear? Okay. Okay. Now, what is this? You tell me. What is this? What is this? Yes. Yes, this is your classical brown tumor. Can you see the brown tumor? Okay, this is, and why am I saying there's also cystic change? See over here, pura faka hai. There's a classic cystic change that has already occurred over here. Now, not only are the kidneys involved, so we have read about the morphology of the parathyroid adenoma, hyperplasia, carcinoma. Now, the primary hyperthyroidism, when it occurs, then what are the skeletal lesions we have already seen? What are the skeletal abnormalities? Osteoporosis, brown tumors, and osteitis fibrosa cystica. Okay. Now, the next very important thing over here is that because, now the first thing was because of increased osteoclastic activity. The second set of lesions that we are watching is secondarily because of increased calcium level. Now, when the calcium level increases, what will happen? It affects the kidney. And what happens in the kidney? There will be increased urinary tract stone formation that is called as nephrolithiasis, is called as nephrolithiasis. Now, not only this, there is also calcification of the renal interstitium and the tubules, which leads to a condition called as nephrocalcinosis. So there is both nephrolithiasis and nephrocalcinosis. And remember, this nephrolithiasis and nephrocalcinosis occurs because of hypercalcemia, whereas these skeletal abnormalities, that is osteoporosis, brown tumors, osteitis fibrosa cystica, it occurs because of increased osteoclastic activity. So remember this, you will be asked about these MCQs, very, very important. What happens because of what is very important over here. Okay. Now, this metastatic calcification. Now, you tell me, what are the two types of calcification that we have read? Yes. What are the two types of calcification we have read? Yes, can you tell me?
Metastatic dystrophic.
Okay, now why it is called as metastatic calcification? Why am I using the term metastatic calcification over here?
Sir, because there is a disturbance in the serum calcium levels.
Yes, very good, fantastic. So now you should correlate. Now is the application that you are watching. Now this metastatic calcification, if you see, it is not only limited to the kidney, but it can also be seen in the stomach, lungs, heart, and in the blood vessels. Okay, is this point very clear? Okay. Let us try and understand about the clinical features of hyperparathyroidism. So clinically, hyperparathyroidism can present in two ways. One is either as a part of asymptomatic hyperparathyroidism. So what do we mean by asymptomatic hyperparathyroidism? That is, the patients have not come to you with signs symptoms of hyperparathyroidism. In fact, the patient has come for you for a routine checkup, and routinely you have done the serum calcium level. So serum calcium was done routinely, and on routine assessment you had seen that the levels of serum calcium levels was very high. So this is what is known as the asymptomatic hyperparathyroidism, and this is how most commonly the primary hyperthyroidism comes into the picture. So most commonly you will see that most of the patients are screened even before the patient becomes asymptomatic because of the regular screening of the serum calcium level. Okay, so most patients of primary hyperparathyroidism, they are diagnosed incidentally. Okay, now very importantly, we have to understand there are three very important MCQs over here. The first MCQ, if you are asked what is the most common cause of hypercalcemia overall, okay, overall the most common cause of hypercalcemia is primary hyperparathyroidism. Okay, secondly, the most common cause of asymptomatic hypercalcemia, asymptomatic, that means without any sign symptoms of hypercalcemia. Okay, the most common cause of asymptomatic hypercalcemia, again the answer will be primary hyperparathyroidism. Thirdly, the most common cause of symptomatic hypercalcemia, when the term is symptomatic, that means sign symptoms of hypercalcemia is there, then the answer will be malignancy. Then the answer will be malignancy. So these are very important three MCQs always asked in the exam. So it should be completely crystal clear as to what are the answers to these MCQs. Now, very important thing is that when we are talking about malignancy associated hypercalcemia, then what are the tumors, okay, which cause symptomatic hypercalcemia? So most commonly these are solid tumors. Mostly the tumors of the breast is most commonly seen. Along with that, lung tumors, tumors of the head and neck, renal carcinomas, along with hematological malignancies. These are all associated with symptomatic hypercalcemia. So very important question over here, that what is the mechanism? What is the classical mechanism of malignancy associated hypercalcemia? That how a osteolytic tumor or how a malignancy is causing hypercalcemia, we have to understand that. This is very, very, very important. Very, very, very important for those who are sitting for the INI-CET exam. This is a repeated question for last 4-5 years. Okay, so very important. So what is the mechanism of tumor or malignancy associated hypercalcemia? Very importantly, it occurs basically because of secretion of a hormone or a polypeptide, which is very much like parathormone, but it is not parathormone. Remember, parathormone is responsible for your primary hyperthyroidism induced hypercalcemia. But malignancy associated hypercalcemia occurs because of secretion of parathormone related peptide. This is not the same as parathormone. Remember this point very carefully. 80% cases of malignancy associated hypercalcemia occurs because of a secretion of a polypeptide which is very similar to parathormone, but it is not the same like parathormone, and this is called as parathormone related peptide. The basic function is exactly the same as parathormone. It is also causing osteoclastic destruction or resorption of the bone. Okay, because this hormone is going to stimulate the formation of osteoclastic precursors. And the function of the basic function, osteoclast is nothing but it is a class of a macrophage. So it is going to phagocytose or eat up the bone and release whatever calcium is there. That is going to increase the free serum calcium level. Second important mechanism is osteolytic tumors, okay, when they metastasize to the bone. So for example, there is a breast carcinoma and that has metastasized to a bone. Okay, so over there, that tumor is going to release certain cytokine, which is going to induce bone resorption. So this is called as cytokine-induced bone resorption. And lastly, the tumors might cause increased production of vitamin D, and that increased vitamin D will cause increased intestinal absorption of the calcium. So these are the very important three mechanisms related with the malignancy-associated hypercalcemia. Should be very, very clear. And remember, malignancy, it is the most common cause of symptomatic hypercalcemia, and the most common malignancy, the first answer should be solid tumors. If they ask you specifically, then most commonly it will be the breast carcinoma causing malignancy associated symptomatic hypercalcemia. And among the three mechanisms, if they ask you which is the most common mechanism, it is the secretion of parathormone related peptide. Now, very important, you have to understand for the lab diagnosis of primary hyperparathyroidism. Somebody was asking me question with regards to the lab diagnosis, that what will be the levels. Now, very important for the diagnosis of hyperparathyroidism, the levels of serum parathormone should be raised. For example, if there's an increased level of parathormone related peptide, then is it primary hyperparathyroidism? No, it is some malignancy associated, some secondary malignancy is there. Okay, some secondary malignancy is there. So this parathormone related peptide assay and PTH assay will help us to differentiate whether it is the cause is primary hyperparathyroidism or whether it is secondary malignancy. The second very important parameter is there is a hyperparathyroidism. So you have to establish that you have an increased calcium level, and even in spite of increased calcium level, the parathormone level is raised. This is showing that there is an autonomous production. Now, when the serum calcium, because when the parathormone is high, then it is going to act on the kidneys, will cause excessive secretion of the phosphate. So the serum phosphate level is going to come down. Now, also very important is increased urinary levels of phosphates, that will be there. Okay, but also not only that, because the amount of calcium is also there, so normal amount of calcium secretion will also become high. So both urinary excessive of calcium and phosphates will be seen. And as in any kind of disease where the bone is involved, the serum alkaline phosphate level will also be raised. Is this crystal clear to everyone? Lab diagnosis of primary hyperparathyroidism. Yes.
Yes, sir.
Clear. Okay. Now coming to the second important so the first important thing that we had read is asymptomatic hyperparathyroidism. That was the most common presentation of hyperparathyroidism. Second very important presentation is your symptomatic hyperparathyroidism. So what do you mean by symptomatic? That means the patient is presenting with signs, symptoms of hyperparathyroidism. What are those? Very, very classically, they say patient is having painful bones, renal stones, abdominal groans, and psychic moans. If I asked you one question right now, can you tell me nephrolithiasis? Okay, it occurs because of what cause? What is the reason for renal stones? Can you tell me? Yesterday I had given 2 MCQs. Let me see if you remember. What is the cause of renal stones? Yes.
Calcium level.
Yes, very good. Increased calcium levels is the cause of, so hypercalcemia is the cause of renal stones. Now I will ask you another question. What is the cause of painful bones? Yes, why there is painful bones?
Bone mineralization.
Painful bones, you have to understand, is occurring because of excessive osteoclast activity, not because of excessive calcium. It is because of excessive osteoclast activity, which is going to cause decrease in the bone mass, that is going to lead to microfractures, and ultimately there will be pain. Do you understand? Yesterday I had mentioned this point very clearly to everyone. Okay, osteoclast activity is responsible. Go back and see the notes I have given, and I have also marked as an MCQ. This is a very important MCQ that is asked. I am repeating again. Now, so what are the symptomatic? Now remember, symptomatic hyperparathyroidism is not the main manifestation. In fact, this has become very less. There's a very decreased incidence. Why? Because till the time the patient comes to this stage, the patient has already been screened and the patient has already been treated. Okay, so now we will understand the different kinds of manifestations of this particular disorder. So the first thing is there will be bone disease. So I've already discussed, secondary to the fractures, because there are fractures of the bones weakened by either osteoporosis or your fibrosis cystica. Nephrolithiasis, as I've already seen, is seen in basically 20% of newly diagnosed patients. The patients are having renal stones. There is an obstructive uropathy the patient will present with. Okay, and chronically, patients who are chronically affected by it will represent with chronic renal insufficiency, which is characterized by polyuria and polydipsia. Now, very importantly, the patient will have GIT disturbances like constipation, nausea, peptic ulcer, gallstones. Especially constipation and pancreatitis are 2 disorders which are very commonly associated with hypercalcemia, or because of increased calcium levels. At the level of the CNS, you will be having depression, lethargy, seizures. Neuromuscular abnormalities include weakness and fatigue. Now, this weakness and fatigue is also called by increased calcium level. So weakness, fatigue, pancreatitis, constipation, all these features are associated with hypercalcemia, mainly hypercalcemia. Then cardiac manifestation, as I've already told you, that there is a metastatic calcification. They are going to deposit in various organs. So there is an aortic or mitral valve calcification. Sometimes there is calcification simultaneously involving both of them, both the valves. Okay. So now basically, before we go to the next tertiary hyperparathyroidism or the secondary and the tertiary variety of hyperparathyroidism, let us try and understand that what are the basic causes of hypercalcemia. So someone was asking me some question. So this is a very basic thing. First of all, whenever you're getting a question wherein you have to decide your answer on the basis of levels of calcium level and parathormone level. So first half of your problem or 70 to 80% problem will be solved by this chart, simple chart. So you have to understand in the question, if you see be any cause, if there is increased free iron levels, and if it is mentioned, see what they are mentioned about PTH. If increased calcium level, normally what will happen? Increased calcium level should decrease the parathormone level normally. So if you see that is not happening, and along with it, there is an increased parathormone level, in that situation, you should understand that if there is an increased parathormone level, then there is an autonomous production of parathormone. That means over here, this production is autonomous. So what are the causes? It is nothing but your primary, secondary, and tertiary hyperparathyroidism. So hyperparathyroidism, as I've already mentioned, primary adenoma is much more common as compared to hyperplasia and accounts for 80% of all cases. And secondary and tertiary hypercalcemia occurs basically because of progressive renal failure. Okay. And one other condition is familial hypocalciuric hypercalcemia that we have already discussed. Can you tell me which mutation is present over here? Yesterday only I have discussed which mutation in which gene is present. Yes. At least say the short form. Have you read? Do you remember? CASR gene. I had spoken something about females taking more time for makeup. Okay. So no one has read yesterday, whatever I have taught. Okay. Now, the other situation is that there is an increased calcium level that is associated with decreased parathormone. Now, very importantly, when the parathormone levels are decreased, what are the possibilities that can occur? Then after that, you are having, so first you rule out them. Okay, first, if the PTH levels are high, then see if any of this option is there in the answer. If the PTH level is less, then you go for these options. Whether the person is having any malignancy. So in malignancy, what did I tell you? Instead of PTH, what is raised? Yes, parathormone related peptide. Okay, parathormone related peptide is raised. Okay, so this is how we differentiate. Okay, hypercalcemia of malignancy versus primary hyperparathyroidism. If you see there is vitamin D toxicity, if the patient is immobile. So for example, if there is any history of fracture or history of anything because of which the patient is bedridden. Okay, so in that condition also this might happen. Any history of drug use like thiazide diuretics. Okay, or any granulomatous disease like sarcoidosis if it is there. So rule out these conditions and 90% of the MCQs will be solved from just this particular chart. Okay. Now we have completed in details about the primary hyperparathyroidism, and now we are going to discuss in details about what is secondary hyperparathyroidism. So any condition in our body which is associated with chronic hypocalcemia. So what is going to happen? What did I tell you yesterday? If the amount of free calcium levels are very low in the body, that is going to cause compensatory overactivity of parathyroid glands. Yes or no? Did I tell you or no? So the parathyroid gland will have to compensate. For example, if the kidney is not working, kidney has become bad, for example, or any disorder because of which the serum calcium level is not being maintained. So as a result, the parathyroid will have to come into the picture and will have to compensate. Okay. So what is the most common cause? What is the most common cause of secondary hyperparathyroidism? It is progressive renal failure. Now, there are other causes also like inadequate dietary intake of calcium, or there is steatorrhea. What is steatorrhea? What is steatorrhea? Yes, tell me. Second year students.
Excretion of fat in
Okay, so if fat is
excretion of fat
lost,
in
then how it is causing hypocalcemia? Why it is causing hypocalcemia? Yes.
It's a defective malabsorption of vitamin D.
Not only vitamin D, any fat soluble vitamins, any fat soluble
Yes, sir.
vitamins,
Yes, sir.
that is
Sir, in this
A,
case, vitamin.
D, E, K, all of them will not be absorbed, fat soluble vitamins. So as a result, in steatorrhea, vitamin D loss will be there, or any other cause of vitamin D deficiency can also lead to this. Especially, I will tell you, in our clinics, any Muslim woman who is coming to the clinic, and those who are wearing, especially the burqa. Okay, so whenever they are wearing, so whole of their body is covered, and you know that for vitamin D synthesis, sun is very important, because there is some reaction in the skin, some cholesterol is converting to something else. I don't remember very vividly what is that particular step, but always when you encounter a female who has covered herself completely, and always stay covered, or especially the housewives who are just inside the home, so in that situation, always carry out both the serum calcium and the vitamin D levels. And you will see in more than 95% of the cases, okay, it is reduced. And that is very, very common cause of reduced calcium levels in these individuals. So I always do this, and always what will happen, you have to give the vitamin D. Do you know what is the dose? Vitamin D, 60,000 units, yes, is given weekly. Yes, for 8 tablets are given for around 2 months of time. Yes, you are reading your pharmacology, yes or no? So this is very, very important. Now, the mechanism for secondary hypoparathyroidism, hyperparathyroidism is very complex and not fully understood. So the mechanism is not given in Robbins. Now, very importantly, over here, because the kidney there's a renal failure, so the kidneys cannot excrete the phosphate also. So as a result, there is a hyperphosphatemia. So increased serum phosphates level, they directly bind with the serum calcium level. Okay, so and as a result, the serum calcium level, they further comes down. So this is further going to stimulate the parathyroid, so to secrete more calcium. Also, one very important mechanism. So these are the plausible mechanisms that they have given, that hyperphosphatemia as well as loss of a renal substance. Loss of renal substance means there's a reduction in the mass of the kidney. So what happens that normally the kidney is synthesizing an enzyme called as alpha-1 hydroxylase, which I suppose, I'm not sure, is converting 1 hydroxy vitamin D to 125 hydroxy vitamin D.
Yes,
and they are
you are right.
producing the active form of vitamin D. They are producing the active form of vitamin D. Okay. So because the entire kidney is filling because of some reason, so kidney mass is becoming less. So the enzyme synthesis, that is the synthesis of alpha-1 hydroxylase, is also coming down. So there is a decreased synthesis of active form of vitamin D. And if the vitamin D is less, intestinal absorption of calcium will be less, and that is going to stimulate the parathyroid again. So these two are the two possible or hypothesized mechanism, and questions are asked on basis of this only. So the basic mechanism of secondary hyperthyroidism is basically hyperphosphatemia and decreased or loss of renal substance, or decreased synthesis of alpha-1 hydroxylase, or decreased synthesis of active form. Any of these options will be there in the MCQs. Okay, is this point very clear to everyone? What are the basic cause of secondary hyperparathyroidism? Okay. Now the lab diagnosis. So I have already discussed the lab diagnosis over there, and I am discussing over here. So over here, very important thing is the parathormone levels are raised. The parathormone levels are raised. Okay, that is there. Very importantly, the serum levels of calcium is low. Okay, and the serum levels of phosphate is very high. So this is the very classical presentation of secondary hyperthyroidism, and because there is a bone involvement, so ALP will be seen. Now, very, very important thing I will tell you, that even though the calcium levels are less, okay, even though the calcium level is less, some amount of metastatic calcification may be seen or can be seen because of the excessive parathormone that is released. Okay, sometimes it is going to cause excessive calcium levels, but overall, if you look at the calcium level, it will always be less. But sign symptoms of hypercalcemia can be seen because there are spouts of increased increased calcium levels. Morphologically, if you see what is happening, what is the end result of secondary hyperthyroidism? there is a lot of stimulation. There is a lot of stimulation of the parathyroid. Yes or no? Because of excessive levels of parathormone. So parathyroid is excessively stimulated. So as a result, what is going to happen? The parathyroid gland, they become reactive. So there is a reactive hyperplasia of the glands. Means all the 4 glands will be hyperplastic in nature. Is this a tumor process or this is a non-tumor? I'm asking, is this a neoplastic or a non-neoplastic process?
Non-neoplastic.
Very good. This is a non-neoplastic process. Very good. So the clinical features of secondary hyperparathyroidism, it is not as severe as it is for primary hyperthyroidism. And the skeletal abnormalities, they tend to be milder in case of this. So the skeletal abnormalities that we see over here, okay, in case of secondary hyperparathyroidism, they are called as renal osteodystrophy. They are called as renal osteodystrophy, and this is much more milder. Now, very important and specific MCQ with regards to secondary hyperparathyroidism is that there is a lot of vascular calcification. So even though the overall serum calcium levels is low, but because of excessive parathyroid stimulation, there are bouts or there are times where suddenly the levels of calcium increases. As a result, this secondary increase in the calcium leads to deposition of the calcium in the vessels, causing significant ischemic damage to the skin and other organs. And this ischemic damage induced by vascular calcification is called as calciphylaxis. Everyone will remember this. What is calciphylaxis? Now, over here, very important thing is the patient responds to vitamin D supplements and phosphate binders, because these are the only 2 abnormalities which is causing this. Over here, there is hyperphosphatemia, which is stimulating the parathyroid. So what do? We give phosphate binders. We are going to give certain drugs which are going to bind the phosphates. And the second thing is we saw that there is an inadequate vitamin D production leading to decreased intestinal absorption of calcium. So we are going to give vitamin D supplements to the patient. Okay, clear to everyone? Okay. Now, next very important is what is tertiary hyperparathyroidism. Now, over here again over here, what is happening? That the parathyroid activity becomes autonomous and excessive. So, very important. The only way you can differentiate tertiary from primary hyperthyroidism. Why I'm saying to differentiate? Because in both the condition, the serum parathormone and serum calcium is raised in both tertiary as well as in case of primary. Yes. But over here, the difference is it is happening secondary to some, secondary to chronic renal disease. Okay, so there is a history of a disease that is there. So the patient had hypocalcemia, history of hypocalcemia will be there. So for example, a patient with a progressive renal disease, a progressive renal failure, chronic renal failure patient, for example, is there. And that patient, okay, this patient was having prolonged hypocalcemia. Okay, and increased parathormone will be there. So now what I did kidney transplant to the patient. I gave kidney transplant to the patient, and now the calcium levels came down to normal, became normal now. Okay, it became normal. Calcium level became normal. So what is the normal thing? The basic parathormone level should have gone down, but this also remained high. Okay, so this is called as tertiary hyperparathyroidism. Is this point crystal clear? Yes, is this point crystal clear? How to differentiate?
टर्शरी में आपने बताया था कि उसके वापस उसका अगर कैल्शियम को ठीक कर गया, मतलब कैल्शियम को ठीक कर दिया गया, तो वापस वो क्या बोलते हैं पैराथॉर्मोन रिलीज होता ही रहेगा.
Yes, that is only I am saying that, see, parathormone initially was being released. For example, parathormone initially was being released because really the calcium level was low. So some people could explain this. Yes, why the parathormone is increasing? Because of reduced calcium level. You can say that people who were in the secondary hyperparathyroid stage have now converted into a tertiary stage. Understand? So patients of chronic renal failure, for example, long-term chronic renal failure is there. Decreased calcium level is there, increased parathormone. So it is a patient of secondary hyperparathyroidism. Now, for example, the patient was given a kidney transplant. So after we gave a kidney transplant to the patient, what happened? After we have given kidney transplant to the patient, then the basic thing is the calcium level now came back to normal. The kidney is functioning normally, producing vitamin D. it is excreting the phosphate, so the calcium level should come down to normal or should become normal. But even after the calcium level became normal, the parathormone remained elevated. This is called as tertiary hyperparathyroidism. So you should be able to differentiate the primary from tertiary, and the only way is to have a history, whether the patient had a history of any disorder or any disorder or prolonged history of hypocalcemia which was recently corrected. That becomes very important.